Welcome back to the Deep Dive. Today we are strapping in for what's a really critical exploration, actually,
Yeah.
specialized pharmacology.
Mhm.
We've got this stack of intense, detailed notes here, the kind that really dictate clinical
You're
action.
right. The practical stuff.
Exactly. And we're jumping straight into the mechanisms, the specific lethal risks, and the absolutely non-negotiable nursing actions. We're talking about hormonal anti-cancer drugs.
That's right. And for those of you listening who want that rapid but really thorough shortcut to understanding these, well, let's face it, dense concepts, this is your deep dive.
Yeah.
We're moving past just simple definitions. We're looking at two major fronts in oncology: treating hormone-sensitive breast cancer and hormone-sensitive prostate cancer.
All right.
Our goal really is to analyze these pharmacological blueprints, not just as isolated facts, but as interconnected systems. We want to focus on those essential trade-offs that, determine patient safety and quality of life.
Absolutely. And the core idea here, it's actually quite elegant when you think about it. Certain cancers, they're opportunistic. They use the body's own natural hormones, estrogen in breast cancer, androgens in prostate cancer, basically as fertilizer to grow and spread.
Right, fueling the fire.
So the therapeutic strategy, it's starvation.
Yeah.
We're using these pharmacological tools to disrupt the endocrine system.
Yeah.
We either block the hormones at the receptor level, stop their creation entirely, or kind of confuse the body's master regulatory system up in the brain.
And that systemic disruption, that's really the key to understanding the entire side effect profile. Every hot flash, every bit of bone loss, every change in metabolic markers,
Yeah.
it all loops back directly to systematically withdrawing or blocking these essential sex hormones.
Yeah.
We're going to go into, well, extensive detail on why those mechanisms matter so much for you, the informed listener.
Okay, let's start with the therapies targeting estrogen. These are used mainly in ER positive, that's estrogen receptor positive breast cancer. And the first, probably the most critical name here is tamoxifen.
Ah, yes.
Tamoxifen is the historical gold standard, and to really get its impact and its risks, we need to unpack its mechanism. It's a bit more complex than just a simple receptor block.
Okay, let's really unpack this mechanism right from the start. We know tamoxifen is classified as a prodrug. Now, for the learner trying to digest these dense concepts, what does that classification, what does that mean for how it actually gets activated in the body?
Yeah, that prodrug status is absolutely vital. It means the pill you swallow, it's biologically inactive.
Right.
It relies entirely on the body's own machinery, specifically the liver, to turn it into its active therapeutic form. So tamoxifen undergoes extensive hepatic conversion.
Okay, in the liver.
Exactly. And here's where the real detailed knowledge comes in handy. The main metabolic pathway involves a specific group of enzymes, primarily the cytochrome P450 enzymes, CYP2D6.
CYP2D6. So the liver needs this specific enzyme to process tamoxifen into its active metabolites, things like endoxifen and 4-hydroxytamoxifen. And these are much more potent, right? Substantially more potent than the parent drug itself.
Yes.
And naming that specific enzyme, CYP2D6, is so crucial for clinicians because of two main things: human genetics and drug interactions.
Oh, okay. Genetics.
Yeah. There are common genetic variations in how active CYP2D6 is. Some people are what we call poor metabolizers. Their liver just can't efficiently convert tamoxifen into that powerful endoxifen.
So they might not get the full benefit.
Exactly. If they aren't producing enough of those active molecules, the drug's effectiveness is severely compromised. This variability means tamoxifen efficacy isn't, guaranteed across everyone, even if they take it perfectly.
Okay, that makes sense.
Yeah.
So once that conversion happens and those active metabolites are floating around, that's when they do their main job.
Right.
Blocking the estrogen receptors on the breast cancer cells.
Precisely. They physically sit on those receptor sites.
Blocking the door.
Blocking the door, exactly. Preventing the natural activating hormone estradiol from binding. It effectively cuts off that growth signal.
And that's why it earned its gold standard status for endocrine treatment of breast cancer. Our sources really emphasize its flexibility too. Approves for both premenopausal and postmenopausal women. That seems like a huge advantage.
It is a massive advantage compared to some of the other hormonal treatments we'll get into. That flexibility is key.
But this is where the conversation gets, well, intense. The side effect profile. It's driven by something called the partial agonist paradox. Let's detail that.
Right, the paradox. It's basically built into the drug's chemical structure. Tamoxifen is a SERM, a selective estrogen receptor modulator.
Okay.
In breast tissue, when it binds to the estrogen receptor, it acts as an antagonist. It blocks activity. That's what we want.
Good.
However, in other tissues, specifically the uterus and bones, it acts as a partial agonist. It causes a slight but clinically significant stimulation of those estrogen receptors.
So it's like a key that locks one door but slightly nudges open two others.
That's a great way to put it, yes.
Yeah.
And that dual action explains pretty much everything about its risks.
Okay, so we can expect the usual estrogen deprivation effects. Hot flashes, fluid retention, maybe some vaginal discharge, GI upset like nausea or vomiting, menstrual irregularities. Those are sort of the expected costs.
Yeah, common, manageable, often.
But we need to zoom in on the two major, potentially life-threatening risks that come from that partial agonist activity.
Absolutely. The first one is the risk of thromboembolic events. That partial agonist effect in the vascular system, it messes with coagulation factors. It leads to a small but definite risk of serious blood clots, deep vein thrombosis, DVT, pulmonary embolism, PE, and even stroke. We're talking potentially fatal events driven by the drug acting, well, too much like estrogen in the wrong place.
Wow. Okay. And the second critical risk?
Endometrial cancer. Again, this comes from that partial estrogen stimulation, but this time specifically in the lining of the uterus, the endometrium. The notes really emphasize that this risk, particularly in postmenopausal women, is something providers have to be super vigilant about. But importantly, these cancers often show up early because there's a specific warning sign: abnormal uterine bleeding.
So if a postmenopausal woman on tamoxifen reports any abnormal bleeding, even just spotting,
that's an immediate red flag. Non-negotiable evaluation. You're looking for signs of endometrial hyperplasia or actual cancer, driven by that unwanted agonist activity.
got it.
Oh, and we should probably mention the initial transient things too. Some women, especially those with existing bone metastases, might experience a temporary spike in calcium levels, hypercalcemia, and maybe a flare-up in bone pain right when they start treatment. It can be alarming, but it usually settles down.
Okay. Now, shifting to safety, there's a drug interaction highlighted in the notes that seems incredibly important to internalize. We're talking about using SSRI antidepressants alongside tamoxifen.
Yes. This is potentially a matter of life and death, and it loops right back to our first point about that CYP2D6 enzyme.
The activation enzyme.
Exactly. Certain SSRIs, especially strong inhibitors like fluoxetine, Prozac, and Proctine, Paxil, and maybe to a lesser extent sertraline, Zoloft, are designed to inhibit CYP2D6.
So if you inhibit the enzyme that activates tamoxifen,
you're essentially rendering the primary breast cancer therapy ineffective. You stop the conversion to the active cancer-fighting endoxifen.
The sources are really clear here. Taking these specific SSRIs with tamoxifen increases the risk of breast cancer recurrence. That's huge.
It's huge. We've seen studies suggesting this combination could lead to maybe up to a 30% higher recurrence rate.
Yeah.
That's not just theoretical, that's a potential clinical failure if that interaction isn't managed rigorously.
Wow. Okay. So the nursing action, the safety counseling has to be absolute.
Absolutely. And beyond just managing drug interactions, tamoxifen is highly teratogenic. It causes birth defects.
Right.
So patients must be instructed, in the clearest possible terms, to avoid taking it during pregnancy or if they're even planning to conceive. Comprehensive reproductive counseling before starting therapy is absolutely essential.
Okay. Now let's move to anastrozole. This one attacks the estrogen supply chain from a totally different angle. If tamoxifen is the receptor blocker, anastrozole is more like shutting down the factory.
Exactly, a plant shutdown. That's a good analogy.
Let's detail the mechanism of these aromatase inhibitors and how they contrast with tamoxifen.
Well, the contrast is significant. Tamoxifen, remember, competes for the receptor site. Anastrozole, it doesn't touch the receptor at all. It inhibits the enzyme aromatase.
Aromatase, okay.
Aromatase is this critical enzyme found mainly in peripheral tissues like fat, muscle, the adrenal glands, and it's responsible for the final step in converting androgen precursors into active estrogens.
So by inhibiting this enzyme?
By inhibiting aromatase, anastrozole dramatically cuts down the total amount of circulating estrogen in the body.
And this different mechanism is why its approved uses are so specific, right? The sources say anastrozole is approved as first-line oral therapy strictly for postmenopausal women with ER-positive breast cancer. Why only postmenopause?
It comes down to where the estrogen is coming from. In premenopausal women, the ovaries are the main estrogen factory.
Right.
And their output is massive. It's hormonally regulated. Inhibiting peripheral aromatase just isn't enough to suppress those tumor-fueling hormones. The ovaries would just compensate.
Ah, okay.
But once a woman is postmenopausal, her ovaries have basically shut down production. Peripheral aromatization then becomes the dominant source of estrogen. So shutting down aromatase in that population effectively starves the cancer.
And this leads us to the key safety advantage, the big trade-off compared to tamoxifen. Because anastrozole works by massive suppression, not partial stimulation.
It completely bypasses that partial agonist paradox we talked about. Meaning it does not promote endometrial cancer or thromboembolic events. That is a huge clinical win, avoiding those potentially lethal clot risks associated with tamoxifen.
That's a defining feature. You eliminate tamoxifen's really severe, unique risks.
Yes. But, and this is crucial, we immediately trade those risks for a completely different and frankly profoundly challenging set of side effects, specifically overwhelming musculoskeletal pain and a significantly increased risk of bone fractures. This trade-off is absolutely critical to understand when managing a patient on anastrozole.
Let's talk about that pain. Because anastrozole drops estrogen levels so drastically, creating this environment of severe hormonal deprivation. It induces effects that sound much more dramatic than tamoxifen's. Our notes list the general stuff: asthenia, which is weakness, headache, hot flashes, vaginal dryness, GI issues, peripheral edema, even hypertension.
Right, those are common. But the musculoskeletal pain is often the chief complaint. It's frequently dubbed Ames aromatase inhibitor-associated musculoskeletal syndrome.
Pains.
And look, this isn't just a little bit of stiffness. For many patients, it manifests as joint pain, stiffness, tendinitis, sometimes so severe it actually mimics late-stage rheumatoid arthritis. It can be truly debilitating, and it directly threatens whether patients will actually stick with this life-saving drug.
So when a patient comes in with this intense, adherence-threatening pain, the nursing guidance in our notes. It sounds like one of the most stringent and honestly difficult instructions in oncology. Treatment with mild painkillers like acetaminophen or ibuprofen, maybe high-dose vitamin D. But the core advice is to tell the patient to fight through the pain.
That phrase, fight through the pain, it really underscores the gravity of the choice here.
Yeah.
We're essentially telling the patient that the risk of cancer recurrence if they stop the drug is so high that they must endure the significant loss of quality of life. The only stated reason in the notes for stopping treatment is that the pain is so bad it prevents them from basic self-care, like literally not being able to get out of bed. It speaks volumes about prioritizing survival, sometimes over comfort.
Wow. And the second major consequence of this profound estrogen deprivation: severe bone loss, increasing fracture risk.
Absolutely. Estrogen is critical for maintaining that balance between building bone and breaking it down. When you remove it so drastically, you accelerate the activity of the bone-destroying cells, the osteoclasts. This leads pretty quickly to decreased bone mineral density.
Which necessitates those mandated proactive nursing strategies for bone health you mentioned. You can't just wait for a fracture.
No, you have to get ahead of it. We must ensure adequate intake of calcium and vitamin D, usually aggressive supplementation. We have to mandate regular weight-bearing exercise, walking, light lifting, things that physically stimulate bone density.
Right.
And for women identified as high risk for fracture, the protocol requires giving a bisphosphonate or denosumab. These are powerful drugs specifically designed to stabilize or even help rebuild bone density.
Okay. And one final crucial point on monitoring for anastrozole. The notes flag the need to notify the provider if a patient reports a headache. Why a headache?
It might seem minor, but it could be a symptom of blood pressure changes. Anastrozole is associated with hypertension. So any new or worsening headache complaint mandates an immediate vital signs check to assess for uncontrolled blood pressure.
All right, let's transition out to prostate cancer. Driven primarily by androgens testosterone and its more potent relative, dihydrotestosterone, or DHT. The goal is the same: starvation. But we're using a different set of hormonal tricks. We'll start with the GnRH agonist, and the main example here is leuprolide. The mechanism of leuprolide is, well, it's arguably the most counterintuitive piece of pharmacology we've discussed so far. It achieves suppression not by immediately blocking things, but actually by initial overstimulation. Can you detail the science behind this downregulation process?
Sure. It involves manipulating what's called the HPG axis, hypothalamic pituitary gonadal axis.
Okay.
Normally, your hypothalamus releases GnRH, that's a gonadotropin-releasing hormone, but it does it in these carefully measured pulsatile doses, like little bursts.
Pulses, got.
These pulses travel down to the pituitary gland, which then releases LH, luteinizing hormone, and FSH, follicle-stimulating hormone. These, in turn, signal the testes to produce testosterone. Now, leuprolide is a synthetic version of GnRH, an analog. And instead of pulses, it continuously stimulates those GnRH receptors in the pituitary.
So instead of the gentle, necessary pulses, the pituitary gets hammered with constant, relentless signaling. What does that nonstop bombardment do to the receptors?
It basically leads to receptor desensitization. The pituitary cells essentially get exhausted and just stop responding. They downregulate.
They shut down.
They shut down. This means the release of LH and FSH absolutely plummets down to near zero. And without those signals from LH and FSH, the testes start producing testosterone. This whole process, though, it takes a few weeks to become fully effective.
And this profound, sustained suppression of testosterone effectively mimics the result of surgically removing the testes in orchiectomy, which is why this therapy is often called chemical castration.
Exactly. It's blunt terminology, but accurate. It's a cornerstone therapy for advanced prostate cancer.
It is, but we have to immediately address the danger inherent in that initial phase, that temporary period before the downregulation fully kicks in. You mentioned the tumor flare.
Yes, the tumor flare. This is critical. When you first start leuprolide, because you're initially stimulating the pituitary before the receptors shut down, there's an immediate but transient surge in testosterone levels.
Okay, and if the cancer cells are fueled by androgens, that initial surge sounds dangerous. What are the specific clinical consequences for the patient?
It can be extremely problematic. The elevated testosterone can temporarily worsen bone pain in men who already have skeletal metastases. And critically, it can aggravate urinary obstruction caused by the prostate tumor pressing on the urethra.
So trouble peeing could get much worse.
Much worse. In severe cases, it can lead to acute urinary retention, needing emergency intervention. The patient can actually feel significantly worse right after starting a drug that's supposed to help them. It's very counterintuitive for them.
So the mitigation strategy here sounds non-negotiable. To protect the patient from this flare, what co-administration protocol absolutely has to be in place?
The sources are crystal clear on this. The tumor flare must be minimized by giving an androgen receptor blocker, something like flutamide, which we'll discuss more soon, concurrently right when you start the leuprolide therapy.
Okay, so you start both at the same time.
Yes. This co-administration is usually temporary, maybe for the first few weeks, but it's absolutely essential. It ensures that even during that initial testosterone surge, the hormone release can't actually bind to and stimulate the cancer cells.
Right, you block the receptors while the levels are high. Okay, let's review the expected side effects then. Since we're essentially inducing chemical castration, the side effects are going to mirror androgen deprivation.
Exactly. Hot flashes are very common, just like with estrogen deprivation. Erectile dysfunction, a profound loss of libido, development of breast tissue, which we call gynecomastia. These are all quite common.
And reduced muscle mass, fatigue.
Yes, reduced muscle mass and general fatigue are also very typical.
Those are the quality of life effects, largely expected. But we need to pivot to the more severe systemic risks tied to long-term androgen deprivation. The notes specifically highlight serious cardiovascular and metabolic side effects, things like new-onset diabetes, myocardial infarction, heart attack, and stroke. That sounds really serious.
It is very serious. This isn't just about feeling lousy from hormone deficiency. We're fundamentally changing the patient's entire metabolic profile over the long term.
Why are these metabolic risks so pronounced when you take away androgens? What's the connection?
Well, androgens, particularly testosterone, play a vital role in regulating body composition, insulin sensitivity, and how we metabolize lipids or fats.
Okay.
When testosterone is severely suppressed for a long time, men typically experience an increase in visceral fat, that deep abdominal fat. This dramatically increases insulin resistance, leading to a much higher prevalence of type 2 diabetes. And this adverse shift in fat versus muscle mass also contributes directly to unfavorable lipid profiles, think higher triglycerides, lower protective HDL cholesterol. This fuels atherosclerosis, the hardening of the arteries, and directly increases the risk of heart attack and stroke.
So we're treating one lethal disease, prostate cancer, but potentially accelerating the risk for another major killer like heart disease or diabetes.
That's the difficult balance, yes. Which brings us back to nursing actions. Just like we discussed with the estrogen inhibitors, the mandated actions for long-term leuprolide use are critical for longevity. We need adequate calcium, vitamin D, and regular weight-bearing exercise to fight off osteoporosis and fractures.
That necessity seems universal for these hormonal therapies.
It really is. Sex hormones are the primary caretakers of bone health. When you suppress them significantly, regardless of gender or the specific hormone, proactive skeletal management becomes absolutely paramount.
Okay, so if leuprolide forces the patient through that initial potentially risky tumor flare before it starts working properly, how do the GnRH antagonists, like dagerelix, achieve immediate suppression without the flare?
The distinction is purely mechanical, how they interact with the receptor, and it's the key clinical selling point for this class. Dagerelix is an antagonist.
Meaning it blocks immediately.
It blocks immediately. It binds to and blocks the GnRH receptors in the pituitary right away. Unlike leuprolide, there's no initial stimulation phase. It just slams the door shut from the start.
Okay.
It achieves the same end result suppression of LH and FSH, leading to dramatically reduced testosterone levels, but it does so without causing any initial surge.
And that difference, the absence of the tumor flare, that's the major clinical advantage then. It makes dagerelix a vital option for patients where that flare risk is particularly dangerous. Maybe someone with existing spinal cord compression from metastases or really severe urinary symptoms.
Precisely. It allows for immediate, safer initiation of androgen deprivation therapy in those high-risk scenarios. Now, when we compare side effects, dagerelix shares the vast majority of the androgen deprivation effects with leuprolide.
So still the hot flashes, reduced libido, ED, gynecomastia, decreased muscle mass.
Yes, and crucially, decreased bone mass with the associated fracture risk. The long-term metabolic risks, diabetes, cardiovascular events, those are likely shared as well, due to the profound testosterone suppression itself.
But dagerelix does introduce its own unique set of adverse effects, mostly related to how it's given.
That's right. Our notes detail common injection site reactions. Since it's a subcutaneous injection, you often see pain, redness, erythema, and swelling right where it's injected. These can sometimes be quite significant.
Okay, and systemic side effects unique to it.
We also see things like weight gain being reported more commonly, and potentially elevation of liver transaminases, those liver enzymes we monitor.
And there's an interesting immunological detail in the notes, too, about antibodies.
Yes, this is something important to clarify for the learner. It's common for patients to develop antibodies against dagerelix over time. However, the crucial clarification is that these antibodies do not seem to reduce the effectiveness of the treatment.
Oh.
Okay.
So if a provider sees antibody formation on a lab test, they shouldn't panic or necessarily switch therapies.
Correct. As far as we know from the data in these notes, the efficacy remains intact despite the antibodies.
Good to know. Now let's talk administration. The nursing notes for dagerelix sound quite specific, maybe more demanding because it aims for that rapid suppression. It comes as a powder.
Yes, supplied as a powder that needs to be carefully reconstituted for subcutaneous or sub-Q injection, and the dosing regimen is critical for achieving that rapid efficacy.
What's the regimen?
It requires an initial, very substantial loading dose, a 240 milligram dose given as 2 separate injections. This is needed to get therapeutic levels up quickly, basically bypassing that slowdown regulation curve you see with leuprolide.
Okay, a big upfront dose.
Right. And this is then followed by monthly 80 milligram maintenance injections. So the administration technique, making sure that powder is reconstituted correctly, and strict adherence to that initial loading dose are all really critical to achieve immediate, effective chemical castration.
Okay, let's complete our prostate cancer pharmacological toolkit with the antiandrogens, using flutamide as the example. The mechanism here feels like a return to receptor blockade, kind of like tamoxifen, but obviously targeting the androgen pathway instead.
Exactly. Flutamide acts directly as a competitive inhibitor. It blocks the androgen receptors located within the prostate cancer cells.
Okay.
By doing so, it prevents both testosterone and, perhaps more importantly, the much more potent androgen dihydrotestosterone, or DHT, from binding to those receptors.
And DHT is really the primary driver of prostate cell growth.
It's considered the primary driver, yes. So by blocking that receptor, you inhibit the downstream signaling pathways that drive androgen-dependent cell proliferation and survival.
Now, the absolutely crucial piece of information about flutamide seems to be its required use restriction. Our sources state it is only approved for prostate cancer and only ever used in combination with either surgical castration or chemical castration using a GnRH agonist like leuprolide. Never used alone. Why is that?
That combination requirement is absolutely fundamental. If you use flutamide by itself, blocking the receptors would actually cause a compensatory increase in testosterone production. The pituitary would sense the lack of androgen effect and ramp up LH and FSH production, trying to overcome the block.
Okay, so it would backfire on its own.
It would essentially backfire. But when you use it in combination with chemical castration, which shuts down testicular testosterone production, flutamide achieves what's known as maximal androgen blockade, or MA.
Maximal androgen blockade, MA.
Right, and MAD is crucial because even after the tests are suppressed by leuprolide, the adrenal glands, and sometimes even the prostate tumor itself, can still produce small amounts of androgens. Flutamide blocks the effects of these remaining androgen sources.
So it serves two essential functions in that combination therapy. First, it completes a blockade, hitting those residual androgens from the adrenals and tumor.
Yes, ensuring maximal androgen blockade.
And second, critically, it acts as that necessary shield to prevent the initial tumor flare when you're starting the leuprolide.
That second function, flare prevention, is why it's so essential during the initiation phase of GnRH agonist therapy. It keeps the patient safe during that potentially dangerous early testosterone surge.
Makes sense. Now, let's talk side effects for flutamide. It shares the expected hormone deprivation symptoms, right? Sexual dysfunction, decreased muscle and bone mass, hot flashes.
Correct. Those are common due to the overall androgen blockade. GI issues are also very common with flutamide. Nausea, vomiting, and particularly diarrhea can be quite problematic for patients.
Okay, but there's a severe, potentially lethal risk associated with flutamide that really demands serious attention. The notes highlight a rare but potentially fatal liver toxicity.
Yes. This is the defining, most serious risk of this older class of antiandrogens like flutamide. It carries a truly lethal hepatotoxicity risk that has, unfortunately, led to fatalities in the past. This mandates extreme vigilance from the entire clinical team.
So the signs of liver toxicity, jaundice, that yellowing of the skin or eyes, dark urine, abdominal pain, severe unexplained fatigue, patients need to know these are emergencies.
Well, absolutely. They need to be educated to report those immediately.
And because of this severe risk, the nursing monitoring protocol sounds incredibly strict. What does it involve?
We are looking at mandated monthly liver function tests, LFTs, checking those liver enzymes during the first 4 months of treatment, and then periodically after that. That initial 4-month window is considered the period of highest risk for acute severe hepatotoxicity.
Monthly blood tests for the first 4 months. That's intensive.
It reflects the seriousness of the potential risk. We also need to mention another serious side effect presentation noted: rectal bleeding, specifically presenting as black Kari stools. That's a significant gastrointestinal red flag, separate from just simple diarrhea.
Okay. And finally, just a safety note, even though its use is restricted to men with prostate cancer, the general safety profile confirms it is, like tamoxifen, highly teratogenic.
Correct. Important to note for anyone handling the medication or potentially exposed.
Okay, we've covered, what, 6 major drugs now, spanning both estrogen and androgen manipulation? And if we just step back for a second, the common thread seems undeniable. These are life-saving therapies, but they require a significant trade-off in quality of life, largely because of the resulting hormone deficiency.
Absolutely. The mechanisms are complex. You've got receptor blockers like tamoxifen and flutamide, enzyme inhibition like anastrozole, and then this HPG axis manipulation with the GnRH antagonists. But the clinical outcome, it forces us into this critical comparative analysis when we're selecting therapy. Let's focus on those major trade-offs. I think these are probably the most valuable nuggets for you to recall quickly.
Good idea. Let's run the comparison for breast cancer first. Tamoxifen versus anastrozole. What's the absolute essential risk profile distinction a provider or an informed patient needs to internalize?
It centers entirely on their different mechanisms. Tamoxifen, being the partial agonist, carries that unique specific risk profile of thromboembolism, those DVTs, PEs, strokes, and endometrial cancer.
Right, the agonist effects in the wrong places.
Exactly. Anastrozole, the profound estrogen suppressor, completely avoids those specific risks, but it substitutes them with the often devastating challenge of severe musculoskeletal pain, AIMS, and that accelerated bone fracture risk.
So clinically, if a patient has a history of blood clots, you probably lean towards anastrozole.
Generally, yes. Whereas if they have severe pre-existing osteoporosis or debilitating arthritis, you might consider tamoxifen first, accepting and managing its different set of risks. It's always a balance.
Okay. Now for prostate cancer. Leuprolide versus daguerreolex. Both achieve chemical castration. What's the immediate deciding difference for initiation?
It really comes down to the tumor flare versus the injection site reaction. Leuprolide, the agonist, causes that initial surge, which mandates the co-administration of flutamide to prevent acute pain and urinary obstruction.
Right. Needs the shield.
Needs the shield. Degarelix, the antagonist, completely bypasses the flare via immediate receptor blockade. That makes it inherently safer for rapid initiation in high-risk patients, but it comes with its own unique challenge of managing those acute, often painful injection site reactions and adhering to that very specific loading dose regimen.
Got it. Flare versus no flare, but injection issues. Let's just reiterate one more time the necessity of combination therapy. Why is flutamide absolutely essential when initiating leuprolide?
Because without it, you are actively putting the patient at risk of acute morbidity, severe pain, potential kidney damage from urinary retention, all due to that initial testosterone surge. Flutamide is a required protective measure to prevent the flare. Plus, it ensures maximal androgen blockade by also covering those residual androgens from the adrenals. It's not just an optional add-on, it's really integral to the safety protocol when starting an agonist.
Okay. Finally, let's synthesize the universal patient management themes. Because there are these crucial repetitive nursing actions that seem to cross all these drug classes, whether we're suppressing estrogen or androgen.
Yes, definitely. The first two themes are those universal bone health strategies. They're critical because of the systemic effects of profound hormonal deprivation, regardless of the hormone.
So number one.
Number one is the consistent need for adequate, often aggressive, intake of calcium and vitamin D. Usually supplementation is required.
Okay. And number two.
Equally important is the mandate for regular weight-bearing exercise. Walking, light resistance training, whatever the patient can tolerate. These are the direct physical countermeasures against that inevitable loss of bone mineral density and the associated fracture risk.
Right. Use it or lose it for bones. And the third theme.
The third theme is drug-specific monitoring, which is tightly built around the most lethal or severe risks associated with each individual drug. Being able to identify those protocols instantly is key.
Yeah, they're not just routine checks.
Absolutely not. These monitoring protocols are like a window into the drug's potential lethality. For flutamide, it's the potential for fatal liver toxicity, hence the mandatory monthly LFTs for the first 4 months.
Okay.
For anastrozole, it's checking vital signs immediately if a headache is reported because of the hypertension risk. For tamoxifen, it's that abnormal uterine bleeding in postmenopausal women demanding urgent investigation for endometrial cancer. The monitoring isn't just routine, it's active hazard management.
So the ultimate takeaway for you, the learner, is really to connect the mechanism directly to the consequence. Understanding how the drug actually works explains why these specific risks emerge. It transforms just memorizing a list of side effects into understanding predictable physiological outcomes.
That connection is real power. The fact that tamoxifen is a partial estrogen agonist explains the clot risk and the endometrial risk. The fact that anastrozole causes profound estrogen suppression explains the terrible musculoskeletal pain and the bone loss. The fact that leuprolide initiates through pituitary downregulation after an initial surge explains the tumor flare. When you understand that underlying physiology, you move beyond rote memorization and into genuine clinical insight and safer practice. #tag outro.
Well, this deep dive has certainly spanned a remarkable range of endocrine oncology mechanisms. We've explored drugs that block receptors, inhibit key enzymes, and even manipulate the master control axis of the pituitary gland. It's incredibly precise, targeted therapy, all designed to extend life by starving the tumor of its fuel.
It is, and it really forces us to reflect on the immense challenges faced by the patients who rely on these therapies. We're asking people to live for years, sometimes even decades, with the consequences of profound hormonal deficiency, things like severe sexual dysfunction, increased risks of heart disease and diabetes, and sometimes, as we discussed, musculoskeletal pain so debilitating, it dramatically impacts their ability to just walk comfortably.
Yeah. And maybe the most provocative thought we should leave you with today circles right back to that clinical instruction we encountered with anastrozole, advising the patient to fight through the pain.
That instruction, it's such a stark reminder of the necessary, difficult calculations made in oncology every day. When a treatment offers a significant chance of cure or life extension, how much sustained suffering is it reasonable to ask a patient to endure? That specific instruction to endure pain that can feel like late-stage arthritis, potentially for years, it reflects the incredibly stringent requirements for adherence to these effective yet deeply demanding therapies. It asks us, really, as providers and as informed listeners, to truly consider the immense ethical weight and the quality of life burden imposed by the necessary, difficult choice to starve the cancer.
A very tough, but absolutely essential, set of details to internalize from today's sources. Thank you for diving deep with us into these complex pharmacological notes.
Our pleasure.
Until next time, keep digging for that knowledge.